Imagine opening a window to cool down a freezing house.
Right, right, just to get a breeze.
Yeah. But your furnace instantly cranks up 10 times hotter to fight back. So you open the window wider to get more cold air in, and the furnace it burns even hotter, completely adapting to outpace whatever you do.
It's the ultimate unwinnable battle.
Exactly. And that is exactly what happens in your nervous system when you take an opioid for chronic pain. The very intervention you introduce to, quiet the pain, it forces your body to build entirely new infrastructure to feel it even more intensely.
It's the ultimate medical double bind.
Mm-hmm.
And we are looking at a deeply fascinating stack of sources today. We've got clinical guidelines, neurobiological research papers, and some really comprehensive data from the New England Journal of Medicine.
It's a heavy stack.
It really is. But the mission for you today is to completely untangle what we call the opioid trap. We're going to separate the biological, microscopic reality of opioid tolerance from the, frankly, incredibly toxic stigma of addiction.
Right.
And then we'll walk through the concrete, evidence-based solutions that can actually break this cycle.
Because for decades, when that internal furnace, our nervous system started burning hotter, we didn't treat it like a mechanical biological response. We treated it like a personality flaw in the patient.
Which is just tragic, honestly.
It really is. So this deep dive is custom tailored for you to understand why painkillers often stop working, how chronic pain physically reshapes the architecture of your nerves, and most importantly, how modern medicine is learning to rewire the thermostat without breaking the furnace.
I love that analogy. To even approach the solutions, though, we first have to fundamentally redefine the problem. Medicine spent a very long time viewing pain strictly as a symptom.
Like an alarm bell.
Exactly, just an alarm bell indicating the tissue was damaged somewhere.
Mm-hmm.
But the modern clinical definition, and this is recognized by the World Health Organization and the International Association for the Study of Pain, it shifts that paradigm entirely.
Right, because chronic pain is defined as pain lasting more than 3 months, right?
Yes. And it is no longer viewed as just a symptom. It is a distinct disease in and of itself.
That is a massive conceptual shift. I mean, you are no longer just dealing with a lingering echo of a healed injury. The pain has become the primary pathology.
Precisely. The protective purpose of acute pain. Telling you to pull your hand off a hot stove.
Right, which is useful.
Very useful.
Yeah.
But it becomes completely obsolete in chronic cases.
Mm-hmm.
Chronic pain creates notable physical changes in your body, fundamentally altering both the peripheral and central nervous systems.
Wow.
So when we try to treat it, especially with a blunt instrument like traditional opioids, we are intervening in a nervous system that has already rewired itself to be hypervigilant.
Which brings us to the core of the trap we really need to dismantle today. The sources emphasize this repeatedly, and it is a misconception that actively prevents patients from getting the help they need.
Oh, absolutely. And it causes doctors to heavily mismanage care.
Right. We have to separate physical dependence from the concept of addiction.
Yes. Because the repeated administration of almost any opioid almost inevitably results in tolerance and physical dependence. It is a highly predictable neuroadaptation.
It's just biology doing its thing.
Exactly. Your body is simply adjusting its baseline to maintain equilibrium in the presence of this new chemical.
Well, and the New England Journal of Medicine piece in our stack points out something truly staggering about the scale of this adaptation.
The dosing data. Right?
Yeah. Because of this predictable tolerance, patients can eventually require up to 10 times their original dose of morphine just to achieve the initial level of pain relief they experienced on day 1.
10 times a dose.
10 times, just to stand still.
And a dose escalation of that magnitude is usually where the panic sets in for the prescribing provider.
Oh, for sure.
They see the chart, they see the climbing milligrams, and the alarm bells ring. But the critical distinction that is so often missed is that tolerance and physical dependence are not addiction.
They're two completely different things.
Entirely different. True addiction is a primary chronic neurobiologic disease. It is characterized by deeply impaired control over drug use, compulsive use, continued use despite severe harm to the person's life, and, intense behavioral cravings.
Wait, I have to stop you there and push back on the numbers in these sources because this blew my mind.
The prevalence data.
Yes. The data says that true addiction occurs in less than 5% of patients prescribed opioids for pain.
It's remarkably low.
Less than 5%. I mean, we are living through a massive, highly publicized opioid epidemic that has decimated communities. How can the true addiction rate in prescribed pain patients be that low? Are we just misreading the data, or is there a massive conflation happening here?
The conflation is exactly the issue. The broader opioid crisis involves a massive influx of illicit synthetic opioids, polysubstance abuse, and a whole host of socioeconomic factors.
Right, it's a much bigger picture.
But when we isolate the data to patients who are actively being treated for legitimate chronic pain under medical supervision, the rate of true psychological addiction, the compulsive destructive behavior, is remarkably low.
Even with pre-existing vulnerabilities.
Even then, the vast majority are simply experiencing biological tolerance.
So if tolerance is a practically guaranteed biological outcome, I mean, if the patient's body is literally just doing its job by adapting to the drug, why has the burden of shame been placed so squarely on the patient for so long?
Well, we have the historical medical establishment to blame for that, unfortunately.
Really?
Yeah. If we look back to older medical texts and previous versions of the Diagnostic and Statistical Manual of Mental Disorders,
The DSM.
right, specifically the DSM-3 and DSM-AV,
Yeah.
published in the 80s and 90s, they actually codified this stigma. Those manuals equated physical dependence and withdrawal with addiction.
Wait, they wrote the biological reality of tolerance into the psychiatric diagnostic manual as a behavioral disorder?
They did. And the fallout for patient care was catastrophic. Imagine a patient in, say, 1995 with a crushed vertebra. They develop natural tolerance and go into withdrawal between doses.
Which is predictable.
Highly predictable. They go to their doctor, sweating and in agony, asking for a higher dose because the original prescription no longer works. The doctor consults the guidelines, sees these symptoms listed under addiction, and cuts the patient off.
Oh my God. Leaving the patient in unrelenting pain, which drives them to the emergency room begging for relief.
Which then gets them labeled as a drug-seeking addict in their medical file. It created this widespread phenomenon known as pseudo-addiction.
Pseudo-addiction.
Yeah, the patient is exhibiting desperate behavior simply because they are suffering and their biology is adapted, but a flawed medical framework mislabels them as an addict.
They're treated as a hostile drug seeker when, in reality, they are just a profoundly undertreated pain patient. That is absolutely heartbreaking. It's like denying someone a glass of water when they are dying of thirst and then diagnosing them with a psychological disorder when they beg you for a drink.
The perfect analogy.
So to fix this, we have to look under the microscope. If we accept that tolerance is a biological certainty, we need to know how the body is actually adapting.
Right. We need to examine the architecture of the central nervous system, specifically a state known as pathologic pain or central sensitization.
Okay, break that down for us.
So when tissue is chronically injured, the body releases specific transmitters. The primary ones acting as first responders are glutamate and a neuropeptide called substance P.
Okay, glutamate and substance P. Those first responders race toward the nervous system to activate specific receptors, right?
Yes. And the most critical one in our sources is the NMDA receptor. This is where the actual mechanics of the opioid trap play out.
The NMDA receptor.
Picture the NMDA receptor like a microscopic, highly secure gate sitting on the wall of a cell. Normally, this gate is bolted shut by a physical magnesium plug.
Okay, so it's locked down tight.
Exactly. But when glutamate and substance P flood the area due to severe, unrelenting pain, they initiate a process that forcefully removes that magnesium plug. The gate flies open.
And the moment that happens, calcium floods into the interior of the cell.
Yes, a massive influx of calcium.
But that calcium isn't just like a generic alarm bell ringing. It's more like a stack of work orders being handed to a construction crew.
I like that. The construction crew in this scenario is a group of enzymes called protein kinases.
Protein kinases, got it.
When the calcium floods in, it wakes up these protein kinases. Inside the cell wall, there's an intricate scaffolding made of structural proteins, primarily PSD95 and PSD93.
Okay, so a structural framework.
Right. These proteins anchor the NMDA receptors to the cell's internal skeleton.
So the calcium rushes in, wakes up the protein kinases, and they grab onto this PSD95 scaffolding to do what exactly?
They start building.
Building what?
With chronic opioid use or prolonged severe pain, these kinases trigger the NMDA receptors to physically upregulate.
Mm-hmm.
The body essentially manufactures and installs more of these receptors along the nerve pathways.
Wait, so it's actively creating new infrastructure to ensure it can feel the pain.
Exactly. It upregulates the whole system.
This is the freezing Hass analogy at a microscopic level. It's like a city that realizes its primary fire alarms are being muffled by the opioids you're taking.
Right.
The city perceives this as a life-threatening vulnerability, so it responds by installing 10 times as many fire alarms on every single street corner.
That's spot on.
Suddenly, the entire city is so hypersensitive that the slightest wisp of smoke or, a piece of burnt toast sets off a massive 5-alarm response.
That phenomenon is central sensitization, perfectly described, and it results in a paradoxical, terrifying medical reality called opioid-induced hyperalgesia.
Opioid-induced hyperalgesia, meaning more pain.
Yes. The opioids themselves actually make the body far more sensitive to pain over time. A prime example in the neurobiological literature is intraoperative remifentanil.
Okay, remifentanil, that's an incredibly potent, short-acting opioid used to keep patients completely pain-free during major surgery, right?
It is. Yet studies show that using it can induce acute rapid tolerance and significantly increase the patient's pain immediately after the surgery is over.
Really? Immediately after?
Yes. The sheer potency of the opioid triggers a massive, aggressive upregulation of those NMDA receptors. The body installs millions of new fire alarms in the span of just a few hours.
So the painkiller literally becomes the pain creator. The very drug designed to turn the volume down causes the nervous system to build bigger speakers.
It's a brutal cycle.
So if we know the NMDA receptor is the engine of this trap,
Hmm.
the magnesium plug is gone, the kinases are building new receptors, and the volume is maxed out, how does modern medicine shut that engine down?
We have to move away from traditional opioids and look at interventions that operate on entirely different chemical pathways.
Okay, like what?
The standout candidate in the recent clinical guidelines is ketamine.
Ketamine. I mean, that carries a lot of cultural baggage as a recreational hallucinogen or a heavy veterinary tranquilizer. It almost sounds counterintuitive to use it for chronic pain management.
It does, but the context of the dosage is everything.
Yeah.
In pain management, protocols utilize subanesthetic doses of intravenous ketamine,
Meaning a very small amount.
a fraction of what is used for anesthesia.
Hmm.
Returning to our microscopic gate, ketamine acts as a potent NMDA antagonist,
Yeah.
but it operates non-competitively.
Non-competitively, meaning it doesn't just try to fight the glutamate to jam the front keyhole of the receptor.
Precisely. It finds a different binding site on the receptor entirely and jams the mechanism from the back.
Oh, that's clever.
But its utility goes far beyond just blocking the gate. Subanesthetic ketamine actively disrupts the unfavorable interactions between the NMDA receptor, the PSD95 scaffolding, and those protein kinases.
Oh, I see. It essentially fires the construction crew. It stops them from building any more fire alarms.
Exactly. And the clinical evidence supporting this is incredibly robust.
What does the data show?
When post-operative patients with morphine-resistant pain are given a small subanesthetic dose of 5-E ketamine alongside their morphine, their pain relief improves dramatically while requiring much smaller doses of the opioid.
Wow, so it makes the morphine work again.
It restores opioid sensitivity. By halting the upregulation of the NMDA receptors, it allows the morphine to do its job without the body violently adapting against it.
That changes the entire strategy. Instead of just throwing more painkillers at the problem, you use a completely different chemical key, the ketamine, to change the locks on the doors the opioids are trying to open.
It's a much smarter approach.
But the sources also highlight another category of drugs. Alpha-2 agonists, like clonidine and dexmedetomidine.
Yes, those are crucial.
If ketamine is changing the locks, what are the alpha-2 agonists doing?
They bypass the local receptor trap entirely and focus on the transmission of the signal. Alpha-2 agonists work independently of both opioid and NMDA receptors.
Okay, so a totally different pathway.
Right. Their primary mechanism is hyperpolarizing presynaptic neurons.
Let's translate hyperpolarizing. A nerve fires by changing its electrical charge, right?
Yeah.
So if you hyperpolarize it, you are making its resting charge much more negative, meaning it requires a significantly larger stimulus to fire an electrical signal in the first place.
That is exactly the mechanism. You're raising the threshold for the alarm to go off. Furthermore, these drugs facilitate the brain's descending inhibitory pathways.
What does that mean?
The human brain actually has a built-in natural system designed to suppress incoming pain signals using noradrenaline. Alpha-2 agonists actively stimulate this suppressive system.
So they turn on the brain's natural pain blockers.
Yes, aggressively reducing the input of pain signals as they travel up the spinal cord.
So if traditional opioids are trying to put out the fire, and ketamine is shutting down the construction of new fire alarms, alpha-2 agonists are taking a pair of wire cutters and severing the electrical line between the alarm and the fire station.
I love that. Yes.
They intercept the signal before the brain even has a chance to register the trauma.
It is a profound shift toward approaching the nervous system from multiple distinct angles, rather than just hammering the same opioid receptors until they break.
Which really forces us to look at the massive pivot in the second half of our sources, because chemical resets, whether it's ketamine or clonidine, are only half the battle.
They are.
Chronic pain doesn't just happen inside a single microscopic receptor. It locks the entire human body into a prolonged state of emergency.
Absolutely. A body constantly battling severe pain is a body trapped in a fight-or-flight stress response.
The sympathetic nervous system is jammed in the on position.
Yes. And this floods the system with cortisol and adrenaline, which prevents cellular recuperation, shreds sleep cycles, and leads to profound systemic wear and tear. You cannot heal a nervous system that is soaking in an inflammatory bath of stress hormones.
And this is where the clinical guidelines heavily endorse holistic, physical, and behavioral resets. We have to look at how to treat the whole system.
It's vital.
Let's start with physical modalities, like deep heat, cold therapy, and targeted compression. On the surface, telling someone with a completely rewired, hypervigilant nervous system to use a hot pack sounds almost dismissive.
It sounds overly simplistic, I know, until you understand the neurology behind the gate control theory of pain.
Gate control theory.
Yes. Applying deep heat, intense cold, or targeted physical compression provides competing sensory input to the central nervous system.
Oh, this is the instinct we all have when we stub a toe or bump an elbow. We immediately grab the area and rub it intensely.
Exactly.
We are intuitively trying to flood the local nerves with movement and pressure signals.
We do that because touch and pressure signals travel along thick, fast-conducting nerve fibers, often called A beta fibers.
Okay, A beta fibers are fast.
Right. Pain signals, however, travel along much slower, thinner C fibers. Because the pressure and temperature signals are physically faster, they reach the spinal cord first.
Oh, it's a literal race.
It is. And when they arrive, they activate inhibitory interneurons that literally close a biological gate, physically blocking the slower pain signals from continuing their journey up to the brain.
Wow. So the brain gets distracted by the fast temperature signal, and the slow pain signal crashes into a closed door at the spinal cord.
That's exactly how it works. And the same physiological principle applies to 10NS units, transcutaneous electrical nerve stimulation.
Right, I've seen those. 10NS devices use mild electrical currents delivered through pads on the skin.
Yes, the current is deliberately kept low enough that it doesn't cause the muscle to contract. Instead, it travels along those fast nerve pathways and creates a massive amount of sensory static.
It scrambles the radio frequency.
Precisely. The slow, methodical pain signal gets entirely lost in the buzzing static of the electrical current before it can reach the conscious mind.
That is fascinating. The clinical stack also presents some really interesting data regarding balneotherapy.
Yes, specifically the use of mud and mineral baths.
Right. The guidelines cite grade 3 evidence that patients with chronic muscle and joint pain obtain significantly more immediate and long-term relief from clinical balneotherapy than from standard spa visits.
Which is really compelling.
But what is the biological mechanism there? It can't just be the relaxation of taking a bath.
No, it is a highly specific combination of thermal mass, hydrostatic pressure, and mineral absorption.
Okay, break that down.
Well, the density of the mud holds and transfers heat deep into the tissues much more efficiently than water alone, which aggressively triggers that gate control mechanism we just discussed.
Ah, the fast beta fibers again.
Exactly. Then the hydrostatic pressure of the mud reduces swelling, and the profound buoyant relaxation forces the sympathetic nervous system to finally power down from its overdrive state.
And powering down that sympathetic overdrive provides the perfect bridge to the most critical and often most overlooked aspect of the clinical guidelines.
The mental health connection.
Right. You simply cannot separate the brain's emotional state from the body's physical state. The sources highlight an astonishing statistic. Up to 96% of patients diagnosed with PTSD also experience chronic pain.
96%. That number illustrates how deeply physical trauma and mental trauma are intertwined at a biological level.
They feed each other.
They do.
Mm-hmm.
When a patient is terrified of their pain, Their amygdala constantly pumps out cortisol and adrenaline. That chemical soup makes the nerve endings more volatile.
Meaning it takes less physical stimulus to trigger a pain response.
Exactly. This is why multidisciplinary approaches, including cognitive behavioral therapy or CBT, are absolutely essential.
But there is a massive stigma around CBT for pain management. Patients often hear therapy and assume the doctor is implying the pain is all in their head.
I hear that all the time. But the sources are clear. The therapy isn't to convince you the pain is fake. It's to physically alter the chemical environment of your brain.
By using CBT to address the anxiety, fear, and catastrophic thinking surrounding the pain, you literally lower the output of stress hormones.
Yes. The same mechanism applies to techniques like the emotional freedom technique, which the sources note can yield significant reductions in pain scores. By systematically signaling safety to the brain, you lower the cortisol.
Which reduces the volatility of the nerves.
Right. You're using neuroplasticity to change the chemical bath the nervous system operates in.
You are telling the body that it is safe to turn off the fight or flight mode, which gives the physical receptors a chance to reset.
Synthesizing all the data from these research papers and clinical guidelines reveals one unavoidable truth. There is no magic bullet for chronic pain.
A single pill cannot reverse a complex neuroadaptation.
It just can't. True success requires a heavily personalized, multimodal approach.
Right, so a patient might genuinely need subanesthetic ketamine to reset the microscopic NMDA receptors, plus a 10S unit to block the signals at the spinal cord, and CBT to lower the systemic cortisol levels.
Yes, to manage the trauma of living in a state of emergency.
It requires recognizing that the patient's biology hasn't failed. It has simply adapted too well.
Beautifully said. Applying these diverse, evidence-based therapies is about systematically unwinding that adaptation to restore the patient's overall quality of life.
Let's bring all of this together for you. We started today looking at a freezing house, and we untangled the opioid trap by separating the mechanical, biological reality of tolerance from the toxic, historical stigma of addiction.
We zoomed all the way in to see the NMDA receptors, the magnesium plugs, and the protein kinases building new pathways for pain.
Then we zoomed out to explore the real-world solutions that bypass the traditional opioid pathways. We looked at subanesthetic ketamine firing the construction crews.
And alpha-2 agonists cutting the transmission wires entirely.
Plus, physical modalities like targeted compression and deep heat utilizing the gate control theory. Understanding all of this profoundly changes how you view the entire human machine.
It really does.
Which leads to a final thought I want to leave you with today. We've seen that something as simple as a competing sensation from a dense mud bath or a targeted electrical pulse from a 10S machine can successfully intercept a pain signal before it ever reaches your conscious brain.
It proves that our perception of pain is highly dependent on which signals the brain receives first and which ones are the loudest.
So, if our daily experience of physical reality is just a matter of which neural pathways are shouting the loudest, and if we can learn to systematically turn down the volume on those pathways to rewire the house's thermostat without breaking the furnace, what other permanent states of being might we be able to rewire?
That is a fascinating question.
Think about it. Keep questioning the assumptions you're handed, stay curious, and we'll see you on the next deep dive.